And last but not least, we have Dr. Julia Rotow. She is the clinical director of the Low Center for Thoracic Oncology at Dana-Farber Cancer Institute, as well as an assistant professor at Harvard Medical School. And she will provide us with updates for EGFR across early stage and the metastatic stage setting. Julia?
Hi, thanks for having me here. So I'm looking forward to chatting with you about some of the updates impacting EGFR mutant lung cancer from ASCO this year. So I'll take you through some highlights from what was presented at the conference in June. So my disclosures. So it's always hard to pick just a few abstracts from ASCO. These are the ones and kind of the themes that I was going to try to talk about with you here tonight. We'll talk about a number of abstracts, all addressing the question of second-line treatment in EGFR mutant lung cancer. We often talk about first-line therapies, as in the first therapy that patients might receive after a diagnosis. But unfortunately, we do know that people will eventually have disease progression and need to go on to the next type of therapy or change therapy. There's a lot going on there as well in EGFR, so I thought I'd talk about some of the data in that space. I'll then talk a bit about some new data looking at EGFR exon 20 insertions, a rare but important subtype of EGFR mutant lung cancer, which requires different treatment strategies than our more common EGFR mutations. And then I'm going to talk about how some of this data that we've had in EGFR over the last years might translate into the setting of treating EGFR lung cancer that's earlier stage or locally advanced. We're thinking about treatment in the perioperative setting. So this is a figure I like to show looking at what does treatment look like these days for EGFR mutant lung cancer. And this is sort of a set of different treatment paths that might be followed depending on what someone might receive in the first line setting is in their first line therapy. So you might hear a lot about getting osimertinib, an EGFR inhibitor, or osimertinib plus chemotherapy, or amivantamab, a bispecific antibody plus lazertinib, a different EGFR inhibitor up front. But of course, after that, there's also a lot of different decision-making to be made about what people are getting next if those treatments stop working. This is some of the options that have been available here over the past year or two. And I'll highlight a few things. One, that this is what we call all-comer treatment strategies. These are mostly treatments that are not based on particular types of acquired treatment resistance, just that everyone was eligible to receive it. These include things like amivantamab, the antibody I mentioned to you, combined with chemotherapy combined with continued osimertinib, or things like antibody-drug conjugates, which are more targeted forms of chemotherapy, like Dato-DXd. But I'll also highlight here this point of resistance match therapies. And we also have a paradigm where in lung cancer, when people are on a targeted treatment and their tumor starts to get resistant, we might resend the same mutation profiling on the tumor we sent before, looking for new gene mutations that it might have developed that might explain why a tumor got resistance to treatment, why the treatment stopped working. This has led to kind of two primary strategies for thinking about when someone gets resistant to initial therapies, usually used with EGFR targeted therapies, where we have this idea of all-comer strategies, which can be started very quickly. They do not require waiting on the results. It might take weeks to get a biopsy and get repeat genomic profiling, versus resistance match strategies, where you might have to do things like a new tumor biopsy or blood-based testing and wait for those results, which can, again, take many weeks, but may be more personalized, may offer oral rather than IV treatment options. And in some settings, especially when we've got a good match therapy, can offer better response rates, potentially looking across studies. So there's two very different strategies, and some people will have a resistance match strategy, some will have all-comer, and it really depends on the results of testing and the urgency of starting therapy. Right now, we have several all-comer regimens that might be used second line, depending what was started in the frontline setting. And just to level set to get everyone in the same place here in terms of understanding what we're using these days, I listed them out here. Again, these are the same things I showed you on that little arrow diagram before, but now just set up against each other and showing some of their outcomes on therapy in terms of the chances of causing a significant decrease in the tumor side. That's that ORR, or the response rate, and how long they tend to work on average. This is the progression-free survival, or PFS, both bolded there. And you can see in general, these regimens, the Mariposa-2 regimen, that's the amivantamab plus chemo, did better than chemo alone, which is our older strategy here. And same thing for osimertinib plus chemo, that did better than chemo alone as well. This was kind of descriptive, where there was less formal cystical testing, but still a common theme that chemo alone is probably not the right strategy for people who've gotten progression these days to an EGFR inhibitor. And I also included Dato-DXd, which is that antibody-drug conjugate. And I'm bringing this up here because right now we only have what we call single-arm studies. There was no randomized study, so we don't have anything to compare it to. So you know how it did. We don't know how standard treatments would have done. So this is where our first ASCO abstract comes in. What about randomized data for an antibody-drug conjugate here after EGFR inhibitor resistance? This was shown at ASCO. This is the OptiTROP-Lung03 study, which asked this exact question. They compared sac-TMT, which is a different TROP2-directed antibody-drug conjugate. So it's a chemotherapy-like drug, which is tagged to an antibody, which sticks to TROP2, which is overexpressed on tumor cells and kind of drags the chemo more to the tumor cells. And you can see here that they compared sac-TMT, the antibody-drug conjugate, to docetaxel, which is a standard kind of single-agent chemotherapy we often use in lung cancer after initial treatment options have been exhausted. And you can see that in this comparison, this was randomized. So part of people on study got the sac-TMT, part got docetaxel, that the chances of response there, those bar graphs on the left, were higher if you had the antibody-drug conjugate. And the duration or how long this seemed to work, the progression-free survival, was also longer, the antibody-drug conjugate, than docetaxel. This is, I think, important. We don't have this particular drug available in the US at this time. This is data from China, but still meaningful, I think, looking at what does it mean if you randomize against standard treatments here with this sort of class of therapies. I'll add another antibody-drug conjugate. This is a very common thing that we're talking about these days in tumors in general, including in lung cancer. So we also had interesting data come out for a different antibody called a MET antibody-drug conjugate. And this is the same idea. It's a chemotherapy-like payload tagged to an antibody, but this antibody sticks to something different on tumor cell surfaces called MET. And the drug was called ABBV-400 or Temab-A. And this was also studied in people who had EGFR-mutant lung cancer who developed resistance. It's a different abstract that was presented at ASCO this year. And this is really interesting to me, at least, I think, artists in the field, because it didn't require selection for overexpression of MET on the cell surface. They didn't have to measure it, say, by pathology or on a biopsy. And it was given alone. It wasn't given in combination with an EGFR inhibitor. And why is that interesting or unusual? We know that oftentimes when people have tumors that are getting resistant to targeted therapies, one of the ways that they can develop resistance is by overexpression of other things that can support tumor cell survival and growth. One of those things is MET. So it's often a form of evolution of resistance. And of course, evolution is heterogeneous. So some tumor cells might get a lot of MET, some might not, some might have other mechanisms of resistance or still be sensitive to the original inhibitor. So there's a lot of variability in tumors as they evolve over time under this evolutionary pressure as they develop resistance. And this means that oftentimes if we're using therapies that target these acquired mechanisms of resistance, you often need the original EGFR inhibitor backbone along with it to try to control the things that aren't resistant while adding something new for the resistant areas. We've seen that before. So Teliso-V is a different MET ADC with a different chemotherapy-like payload, like using a different chemo. And here you can see that you actually had to select for tumors that had overexpressed or high levels of MET on their cell surface. And you could get from low response rates to a little higher response rates if you had higher levels of MET expression. But in EGFR lung cancer, even with very high levels of expression, if you gave the drug alone, you weren't getting very high response rates to therapy. Now, if you added the EGFR inhibitor I mentioned before, continued the EGFR inhibitor backbone along with the MET antibody-drug conjugate, you got much better response rates, going from 16% on that one study to 58% on this one. So it did seem to work better if you gave it in combination. So we kind of expect when we see this data. That's why this data is interesting. This is that abstract from ASCO looking at a different MET ADC, so same cell surface target, but a little different structure and a different chemo being delivered. And what we got here was they did not require selection for overexpression of MET, and they gave it alone. There's no EGFR inhibitor along with it. And this is what they showed in their outcomes. And the key takeaways I had here was that the response rate was really good. It was actually 63% of patients had a good response. That is definitely better than the 16% I showed you here. And of course, that's cross trials, so it can be different patient populations, but interesting and something I think we're keeping an eye on. And we really want to understand, when do you need biomarker selection for antibody-drug conjugates, when you can give one alone, when do you need to give it in combination? That may be different from every drug. Now, I will point out this data, which I'm going to do quickly for sake of time. There was another antibody-drug conjugate called HER3 DXD, which targeted a different cell surface thing, HER3 on lung cancer cells. If you've been following EGFR for a while, you know that we've been watching for this data. This is the big randomized study, which unfortunately was a negative study. So right now we don't see this drug currently expected to get FDA approved, at least in the near future. Just pointing this out, because if you're waiting for on this, I think it was data we were watching for at ASCO. So a little bit of improvement in progression-free survival by less than half a month, so less than 2 weeks, but not improvements in overall survival, and it not being submitted to be at least evaluated by the FDA right now. So we talked a little about resistance match treatment strategies, and I commented about targeting MET. And this is the kind of the spectrum of what we find if you do that repeat profiling of a tumor that's gotten resistant to an EGFR inhibitor. And what we're really looking for is some new DNA alteration or new protein alteration that might, one, explain the cancer resistance to therapy, and or two, be actionable with another targeted treatment so that we can do something about it. And I've highlighted some of them here that likely meet those criteria that we do pick up. In about a quarter of patients or a little less, we find something like this. And I'm going to highlight here that among these targeted combinations, we often think about combining them with the EGFR inhibitor, trying to cover both the original thing and the new acquired resistance. And I'm going to focus here on MET again, because this is the most common thing that we find at acquired resistance. It makes the largest portion of this little pie chart of identifiable resistance. I talked about MET ADCs a moment ago as one way we target them. I'm also going to talk about a different strategy, which is a MET tyrosine kinase inhibitor, or a pill that's MET inhibitor based. And that's because we had 2 studies that came out at ASCO this year looking at the same strategy and actually the same drug combinations. This is for people with an EGFR mutant lung cancer that's gotten resistance to the EGFR inhibitor and on repeat testing had some form of a problem with MET that seemed to be driving resistance. And they measured it a couple of different ways, either in the DNA overexpression, in the DNA too many copies of MET, or on the cell surface too many copies of MET there. But the similar idea, problems with MET driving resistance. And they both looked at continuing osimertinib or using osimertinib, the EGFR inhibitor that we're often using here in the US, combined with savolitinib and MET targeted therapy pill. So like osimertinib targets EGFR, savolitinib targets MET. And they looked at these combinations either compared to chemotherapy alone, which has been kind of the old school standard, or compared to just doing a MET inhibitor alone, basically. And asked 2 similar but different questions. And the takeaway in both cases is that the combination was better than chemotherapy, and the combination is better than giving just a MET inhibitor alone. And that's what this data shows here. This is comparing the combination to chemo by itself, kind of what would be standard or textbook in many places around the world. You can see that doing this, you got a better progression-free survival. So again, the average duration of effect was longer, and a little better response rate as well in terms of the chances that the tumor would shrink in size significantly. And similarly, if you compare it to doing a MET inhibitor alone, so stopping the EGFR inhibitor entirely here and not replacing it with something like chemotherapy, things were definitely more effective with the combination. So again, better progression-free survival and also much better response rate here, much better, 58 versus 16%. And this again goes along with the idea that some of the tumor cells will have MET driving them, that resistance, but not all. So if you just target the MET here, you're losing the rest of the tumor population from being under control. So that kind of makes sense why this would be so different with the combination versus the MET drug alone. All right, changing gear, I'm going to talk about data from EGFR exon 20 insertions. This is just to kind of give people a roadmap for what's going on right now with EGFR exon 20 insertions. These make up about 15% of EGFR lung cancer. They were hard to target because they're harder to make a drug that sticks to that without causing excess toxicity by hitting other proteins in the body like normal EGFR. We do have now a long series of therapies available, typically starting with the chemotherapy amivantamab combination. Then we have an EGFR exon 20 TKI, a pill-based form inhibitor that's been approved, though not yet quite available in the US, we hope soon. We have antibody-drug conjugates that are accessible here, and then standard chemotherapy. I'm going to focus here on this topic of EGFR exon 20 targeted inhibitors, because these are a newer class of therapies for us, and they're EGFR inhibitors that are designed to try to bind to that more difficult binding point on EGFR to try to shut down the abnormal EGFR while trying as best as possible to spare healthy EGFR and therefore kind of get a better balance of effect against tumor versus effect against healthy cells. So I brought this up because there was an interesting abstract at ASCO trying to look at the question, what happens when you sequence these different types of EGFR exon 20 therapies, not just use alone and look at what it looks like. What happens in the real world are using these one after another if you sequence them after each other. So this study looked at zipalertinib, a different EGFR exon 20 pill that's not currently approved in the US, but well along in clinical trials. And they said, what happens if you give it people who've only had prior chemo and nothing else directed against exon 20 insertions? And what if you give it to people who've had prior amivantamab or prior exon 20 inhibitor pills? And how does it do? And what does the efficacy? Because that's what we really are going to be looking at in the real world. So this is what the data showed. It's a bunch of response rates across, and durations of response across a lot of different populations. But basically, they looked first at just everyone who enrolled and people who'd never had exon 20 insertion targeted therapy. And then they looked in more detail, but people with various forms of prior exon 20 insertion therapy, so getting this in sequence with other treatments. The takeaway is that response rate, chance of good tumor shrinkage, was about 40% if you just had prior chemo. That was kind of best case scenario. The tumor had never seen anything directed towards exon 20 before. And then if you'd had prior amivantamab, that EGFR antibody we're often using first along with chemotherapy, response rate was a little lower, 30%, because the tumor had seen something targeting exon 20 in the past. So still a reasonable response rate. And the response rate did get quite a bit lower if you'd had other prior exon 20 insertion targeted pills. And that makes sense. These current generations of pills are probably very similar to each other and really aren't necessarily meant to overcome resistance to each other. All right, I'm going to take a few minutes and just change gear completely and talk about one abstract looking at what about resectable EGFR mutant lung cancer. And the big update from ASCO was trying to look at what happens if you give EGFR inhibitor pills before surgery for patients with this diagnosis. So this is what things looked like in resectable lung cancer in general until a few years ago. People would have surgery up front, and then they would have chemo post-op. It was called adjuvant or post-operative chemotherapy. We know this improves chances of survival, but the relapse rate was still really high. 2/3 of patients living at 5 years, 1/3 living with stage 3 cancer at 5 years. So still a lot of people having relapses or complications down the line. In general, not thinking about EGFR lung cancer, this is where we stand now, where people are getting, as you saw in one of our prior talks, things like modern forms of therapy, like immunotherapy in the perioperative setting, typically preoperatively, and then maybe postoperatively. And this has improved outcomes. It's improved the chances of completely eradicating the tumor. This is the probability of a complete response, so no living tumor seen on the surgical sample. And it's here it went from 2% to 24% by giving immunotherapy along with chemotherapy pre-op. And that improves survival, so how long people are living compared to just getting chemotherapy alone. But of course, what about EGFR mutant lung cancer? Unfortunately, in EGFR mutant lung cancer, immunotherapy is just not as effective, and it tends to have very low response rates, increases toxicity of subsequent EGFR-directed therapy, so we typically avoid it. So what are we doing here? And the answer is in EGFR lung cancer, again, leading up until ASCO, patients have really been getting surgery, then their chemo post-op just like before, and they're also getting a tail of 3 years of osimertinib, the EGFR inhibitor, as a consolidation or adjuvant strategy. And that's improved outcomes for patients. But there's always this question, well, what about preoperatively? Is there any benefit to giving an EGFR inhibitor before surgery, just like we give immunotherapy before surgery in other patients right now? And this was the NeoAdora trial, which looked at this. And the goals of this kind of treatment might be to do things like shrink tumor to make unresectable disease possible. The study didn't actually look at this. We often do this maybe in clinical practice if we're really close to being able to do surgery. Maybe make the surgery smaller in people who even can have surgery. Maybe you just need 1 lobe removed instead of 2. Try to increase the chance of getting it all. So getting complete resection, getting clean margins if you can shrink it back from difficult structures. Maybe understand how well the tumor responded to treatment. As I mentioned, you can look under the microscope and say, how much of the tumor is left after surgery? And you can maybe question, can that improve survival? And are we actually modifying the course of the cancer by doing this sort of thing? With immunotherapy, I think we probably are. We're triggering an immune response against the cancer that can have memory. We think it probably does have some long-term impact on biology of the disease and definitely improve survival now. And EGFR, though, we don't know yet. So this is a different setting. What about using a targeted therapy here? This is the NeoAdora study from ASCO again. This looked at saying, okay, we're going to take lung cancer with an EGFR mutation that can be removed surgically. Instead of going straight to surgery, people will either get standard chemotherapy, osimertinib EGFR inhibitor alone, or osimertinib combined with chemotherapy, like we're now doing in stage 4 or more advanced disease, and then look at outcomes of surgery and after surgery. And the takeaway was one, that most patients got surgery as planned, 88 to 95%. And it was a little more likely to get to surgery if you had osimertinib or osimertinib plus chemotherapy in your preoperative regimen. So it's a little better than chemotherapy there. People are less likely to, for example, to have disease progression as a reason for not getting surgery. And you can also look at how well did the treatment kill the tumor. This is the percent of viable tumor. And you can see that the waterfall plots there, the farther the bar goes down, the more tumor that was killed. And ideally, you want the plot all the way down at the bottom. That's 100% of the tumor dead. That's called that complete response. And I will say across the board, complete responses are low on EGFR targeted therapies, pre-op and EGFR lung cancer. So they are between 4 and 9% here with osimertinib, OC plus chemotherapy. And that's not as good as the numbers we see for things like immunotherapy and other lung cancer populations. But still, it was better than what you see with chemotherapy, where there were no complete responses and only 2 major pathologic responses. That means only 10% of the tumor is left. So my takeaway here is that if you're going to give preoperative therapy these days, we're not going to give chemotherapy alone. We're going to give osimertinib or osimertinib plus chemotherapy, trying to get a better response. Now, we don't know what effect this will have on long-term survival just yet. That takes too much longer to follow the patients who were treated on the study to understand that. But certainly there are patients right now who do require this form of therapy, say they've got a tough, bulky tumor, a lot of lymph nodes involved. And then if we're doing this, we're probably doing one of these EGFR inhibitor combination strategy right now. So my takeaways, there are multiple new treatment strategies to improve outcomes for lung cancer in the second line setting, with all comer and resistance matched. There are novel exon 20 inhibitors that continue in development for a more difficult population of disease. And there may be some role preoperatively for some people with EGFR TKIs when they have an EGFR mutation and resectable cancer. So thank you, and I'll stop there.